And with this, we come to the last session before lunch today. And I would like to welcome Dr. Kalyan Kr Gangopadhyay to speak on this particular session. Repurposing Antidiabetic Pharmacotherapy, the new cure for all the risk. So he is going to speak on this particular topic. I would like to introduce him first. He is a renowned endocrinologist and diabetologist with vast expertise in this field and is attached to Peerless Hospital, CMRI Hospital and Fortis Hospital. To chair this particular session, I would like to invite very senior consultant endocrinologist Dr. Dasarathi Sarkar. He is also the patron of Howrah Town Diabetes Study Society. Along with him, I would like to invite Dr. Mary D. Cruz ma'am, who is a physician and diabetologist, and Dr. Shattoki Manna, who is a consultant endocrinologist from Howrah. I welcome all the chairpersons on the dais and request them to kindly introduce our speaker today.
Good afternoon, everybody. You know that is a long journey of anti-diabetic drug since inception in 1921 insulin, and then the different modifications of insulins. OHA starts at 1950 sulfonylurea, then 1960 metformin, then other OHAs has come, AGI, then the glitazone, then the DPP-4 inhibitor and GLP-1 receptor agonist, and last SGLT2 inhibitor. It's a long journey. But our motto of these drugs mainly to control the blood sugar. And control of blood sugar causes the diminution of the different complications of the diabetes. But now the different guidelines have projected the different things. They are advocated to start the different drugs, particularly cardiac friendly, the renal friendly, hepatic friendly, and drugs to control the heart failure drugs. They should be started very early to control the diabetic complications. So this part will be highlighted by our renowned endocrinologist and diabetologist, Kalyan, Dr. Kalyan Gangopadhyay. Over to Kalyan.
Thank you, sir, for your kind introduction. So, when I first received the topic, আমি ঠিক বুঝতে পারিনি টপিকটা কি। তারপরে কিছুক্ষণ ভাবার পরে হলাম যে কি repurposing new cure for all the risk. So then I thought probably the meaning is that you think about heart failure, CVOT and CKD. শুনে 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 কান পচে গেছে, তার মানে আর না, ওটা বলবোই না আমি। So I will say something else that we discuss less often, discuss nevertheless, but less often. So I will go into that. We all know about GLP-1 and SGLT2 reducing the CVOT, SGLT2 in particular reducing HFrEF and HFpEF. So we all know this, CKD reduction আছে, তা আমি একটুখানি ডিফারেন্ট অন্য ট্র্যাকে যাব। So I will first say a few words about non-albuminic kidney disease. So urine ACR less than 30 into GFR less than 60. So overall, literature says 20 to 40% of our patients, they have normal albuminuric kidney disease, 20 to 40%. It is possible that this phenotype might follow a different pathophysiological pathway than albuminic decay. Ebare, this is the study which I have been part of this study. We have not published it here. We are still collating the data. This is from one of the largest studies in India, collating data from all over India. Patients with type 2 diabetes and CKD. So either they have GFR less than 60 and or ACR more than 30. So in there, you see here, the main green bit here is eGFR 30 to 300, and about 9% of patients had eGFR less than 30. But I told you, foreign data, Western data is 20 to 40% have got normal albuminuric. This is our Indian data, which suggests roughly around 9 to 10% have got normal albuminuric DKD. Now the difference is this. This is the best article that I could get on this. So if you see albuminuric DKD, there is more of small vessel microangiopathic changes, and in non-albuminic, there you get more of macroangiopathy. There is less correlation with retinopathy. There is more of tubular and vascular damage and more in female sex. and there is less correlation with HbA1c. So there's a bit of difference between albuminuric and non-albuminuric DKD. And if you look at the outcome data, so this is the data with advanced trial, cardiovascular events, cardiovascular death, normoalbuminuria and GFR less than 60. তাহলে এটাকে CKD বলবো কারণ GFR less than 60 হয়েছে. If you see here, cardiovascular event rate is 1.33, মানে 33% more. কিন্তু যেই অ্যালবুমিনুরিয়া হয়ে গেল আর GFR less than 60 যদি হয় তাহলে এটা double from than the reference. So what it means basically is non-albuminic DKD is less, or rather I would say the terminology ta bhul hobe, albuminuric DKD 30 er upore gele it is more dangerous than non-albuminic DKD. So this is what from the advanced post-op analysis you can see data from the CV events, and this is CV death. So eta almost equivalent to albuminuria with GFR more than 90. You can see this here. So you can see this here. This is similar. Now the problem is there is no trial till date to see whether pharmacotherapy can help non-albuminuric DKD in type 2 diabetes. No trial dedicated for non-albuminuric DKD. Although, as I said, about 20 to 40% may have that of all the DKDs. So this is the conglomeration of all the trials. You can see this is ACR and this is EGFR. So all these Finrenon, renal, DKD, DAPA, CKD, everything falls here. But our urine ACR line is 30 is here. Below that, you cannot see any trial available till now. The only extrapolated data that we do, and before that, the KDOQI, the recent one, has mentioned that normotensive, no albuminuria, RAS blockage is not, they have mentioned this, is not beneficial. They have not said that probably not, orukom noy, likhe diyechi, is not beneficial for patients with neither albuminuria nor elevated blood pressure. So I see a lot of prescriptions in patients with type 2 diabetes, ekhane boleche je apni ei oshudha khan apnar kidney protected থাকবে. যদি অ্যালবুমিনুরিয়া না থাকে আর প্রেশার যদি কম থাকে তাহলে কোনো রোল নেই, এটা লিখে দিয়েছে পরিষ্কার, নট বেনিফিশিয়াল। সো আমরা যদি দেখি তাহলে এক্সট্রাপোলেটেড ডেটা আমাদের SGLT2 রয়েছে। এখানে you can see EMPA-RAGE, ACR less than 13, 60%, Canvas-এ mean ACR was 12, Declare-TIMI-তে more than 70% had ACR of less than 30. তো খালি ACE inhibitory ট্রায়ালগুলোতেই এক্সট্রাপোলেট করে দেখা গেছে যে হ্যাঁ। So if you see repurposing without any trial evidence, then আমাদের SGLT2 আসবে। In there, if you compare the three cadence, DAPA, CKD and EMPA kidney, only EMPA has got EGFR less than 30, urine ACR less than 30, 20% of the patients, which is a big number. 1200 patient with albuminuria less than 30, mind you. So it is 1200, not a small number. And here in this group, giving empagliflozin, this is the EGFR slope. This is the absolute difference and this is the relative difference. Eta ekhane asbe actually. So if you look at the urine ACR less than 30 hole pore, ami relative difference যদি দেখি, it seems to be 86%. আর higher albuminuria তে around 50%. But এই ইন্টারপ্রিটেশনটা একটু ভালোভাবে বুঝতে হবে। দিস ইজ রং। এটা দিয়ে কখনো বলবো না যে যাদের ইউরিন ACR লেস দ্যান 30 তাদেরকে বেটার কাজ করেছে। নো, রং। কেন? 10-এর মধ্যে 1 হলো গিয়ে 10% আর 5-এর মধ্যে 1 হলো গিয়ে 20%। এদের EGFR স্লোপ প্লেসিবোর, যাদের ইউরিন ACR লেস দ্যান 30 আছে তাদের EGFR স্লোপে যে রেট অফ ড্রপ সেটা অনেক কম। তার মধ্যে কিছুটা কমিয়েছে, 10-এর মধ্যে 1 কমিয়েছে, দ্যাট ইজ 10%। আর এদের অনেকটা বেশি তাড়াতাড়ি স্লোপ হয়ে গেল, 5-এর মধ্যে 1 20%। সো ইউ হ্যাভ টু টেক ইট ইন কনটেক্সট। বাট রিগার্ডলেস টু সে দ্যাট even in patients with urine ACR of less than 30, which is about 1200 patients, it showed that it reverses. This is perhaps the best evidence we have and repurposing diabetes in this group of patients. Next, I come to sleep apnea. Now, this we all know, যতগুলো পেশেন্টকে আমি বলেছি 100টাকে যদি বলি সিপ্যাপ ওএস এর স্লিপ স্টাডি করুন, ও হয়তো 2-3 জন করবে, তার মধ্যে সিপ্যাপ লাগলে একজন নেবে। But the problem is more than 80% of individuals with OSA remain undiagnosed despite adequate access to healthcare. And unfortunately, CPAP therapy যেটা আমরা দিই পেশেন্টদের, সেখানে অ্যাডভার্স কার্ডিওভাস্কুলার আউটকাম অ্যান্ড ডেথের ডেটা খুব একটা ভালো নেই। So we don't know whether CPAP therapy, it might make them more awake, sleep quality better হবে, কিন্তু ওটা কি কার্ডিওভাস্কুলার ডেথ কি কমাবে? We don't have data. যে ডেটাগুলো আছে which is conflicting. So we cannot say for sure যে CPAP নিন আপনার কার্ডিওভাস্কুলার ডেথ আমি কমিয়ে দিতে পারছি। No, we can't say that. At present, there is no pharmaceutical intervention that has been approved for the treatment of obstructive sleep apnea. That is why the repurposing. I had written a chapter on sleep apnea in a textbook, metabolic syndrome. মানে স্লিপ অ্যাপনিয়াটা অতটা সোজা নয়। ক্রনিক ইন্টারমিটেন্ট হাইপো, আমরা 8 ঘন্টা যদি ঘুমাই, 1/3 of the time we are asleep. এই 1/3 of the time যদি আমাদের ক্রনিক ইন্টারমিটেন্ট হাইপক্সিয়া হয়, that leads to a lot of things, sympathetic activity, gutter microbiome change হয়ে যায়, so a lot of things happen, and ultimately there is a lot of inflammation also takes place. So maybe এই জন্যই সিপ্যাপের বেনিফিশিয়াল এফেক্ট হলো না বোধহয়, কারণ ইনফ্লামেটরি অ্যাসপেক্টটা সিপ্যাপ ডিল করছে না, খালি মেকানিক্যাল অ্যাসপেক্টে ডিল করছে সিপ্যাপ। সো দিস হ্যাভ, we talk about heart failure. So it is apnea hypopnea index more than 15 is severe, more than 5 is mild, moderate, severe. You can see HFrEF-A. Look at the huge volume of patients. About 50% of patients have got at least some degree of obstructive sleep apnea. And this is true for HFpEF patients as well. About 30% of patients or to 60% of patients have got it. This is a problem, and we don't deal with it directly. Now the SGLT2 repurposing it, this has got good, theoretically at least, good benefit. The why it is, so if you use, diuretics have been used in obstructive sleep apnea, conflicting results. কেন ফ্লুইডটা কমিয়ে দিলাম, তো এখানকার ফ্লুইড কমে গেল, তাহলে আমি ব্রিদিং ভালো হবে। ঠিক ইন্ট্রাভ্যাসকুলার ব্লাড ভলিউম কিন্তু কমাচ্ছে। দিস ইজ বুমেথানাইড অ্যান্ড দিস ইজ ব্ল্যাক ইজ ডাপাগ্লিফ্লোজিন। সো বুমেথানাইড অনেকটা ব্লাড ভলিউম কমাচ্ছে, ডাপাগ্লিফ্লোজিন অতটা কমায়নি, কিন্তু ইন্টারস্টিশিয়াল ফ্লুইড ডাপা অনেকটা বেশি কমিয়েছে। সো ডায়রিটিক খেলাম, আমার ঘুমটা ভালো হবে, এখানকার ইডিমা কমে গেলাম, যেই শুয়ে পড়লাম দ্য ফ্লুইড, দ্য ব্লাড ইজ রিডিস্ট্রিবিউটেড, আবার সেই জমে গেল। দ্যাট ইজ ওয়াই দ্য ডেটা উইথ ডায়রিটিক্স ইজ কনফ্লিক্টিং ইন OSA. বাট উইথ SGLT2 inhibitor, because it reduces the interstitial fluid more, therefore you get benefit. So this cartoon tells you যে এখানে interstitial fluid edema হয়ে আছে, এটা intravascular, তো loop diuretics এ intravascular ভলিউমটা কমছে, কিন্তু এখানে এইটা কমছে না, interstitial edemaটা কমছে। Now these are the few trials which have been done of SGLT2 inhibitors in patients with OSA. These two are the actual trials, a retrospective cohort, and this is randomized controlled trial. I will use this, it will be better. Oh, Rashchana. So here, this is the two proper studies. This is derived from the EMPA-REG outcome study. Ota theke extrapolated data. And here you can see, ye dutote, both of them, p-value significance, they reduce the AHI from 31 to 18, which is quite significant. Now with the EMPA-REG trial, there was a 52% reduction in progression to OSA, but how about the cardiovascular mortality and all-cause mortality? So see here, this actually is statistically not significant, but this all-cause mortality is, and this all-cause mortality reduction is about 68%, which is much more than the all-cause mortality reduction overall in the EMPA-REG study. So therefore, if I am suspecting OSA and if I give SGLT2 inhibitors, then I can tell the patient there is a good possibility that it might reduce the all-cause mortality just based on the OSA bit as well. So that's repurposing it for this. Now, obesity is related to obstructive sleep apnea. You have got multiple trials with obese patients and with diabetes patients. So we got orforgliprazine, semaglutide, we got survodutide, now tirzepatide, triple agonist, retatrutide. You can get up to 25% drop, you can see here, in non-diabetic. So I badly need it, কারণ আমাকে যেটা দিল আমি পড়তেই পারলাম না, ওগুলো খুব টাইট হয়ে গেছে। বলে এর থেকে বড় সাইজ নেই, so which is good. So that gives me stimulus to reduce my weight. এবারে the data with GLP-1 receptor agonist and OSA is this. These two, the romance study and there is another study which is ongoing. These are properly done dedicated trial for OSA patients. এখন অবধি খালি extrapolated dataই আছে, এখানেও extrapolatory retrospective observational study. এইটা perhaps একটা ভালো study দেখা গেছে যে daily dose of liraglutide দিয়ে কি করা হয়. This was a very good trial and this is just published just 3 months ago in NEGM. Tirzepatide, এখানে দুটো গ্রুপকে দেখেছে OSA, one who were receiving CPAP and one who wasn't receiving CPAP. They wanted to see what is the effect of tirzepatide in this group. This was a properly done trial, dedicated for sleep apnea. And you can see there is a mark, jara CPAP নিচ্ছে না আর যারা নিচ্ছে দুজনেরই খুব ভালো drop in the apnea hypopnea index. So you can see here placebo comparison about 20 less দুটোতেই. So this is quite, এবং আমি এটা বললাম যে CPAP মেকানিক্যালি করছে কিন্তু অ্যাডভান্টেজ পাওয়া যাচ্ছে না সিভি আউটকাম, এগুলোতে অ্যাডভান্টেজ পাওয়া যাবে সিভি আউটকামে বিকজ ইনফ্লামেটরি পার্ট ওএসের সেটা আমরা ডিল করছি. হোয়াট ইজ দি ডেটা উইথ GLP-1 প্লাস SGLT2? I don't know yet, but I'm sure it will be very good. So I've got another 5 minutes. I'll just wrap up very quickly. Depression and diabetes. Patients with diabetes have double incidence of depression. And various studies, 18 to 30% of our patients have got depression. Depression নিয়ে কথা বললেই আমরা ডিপ্রেসড হয়ে যাই, কে আবার দেখবে পেশেন্টকে জিজ্ঞেস করলে আপনি কি ডিপ্রেস? না আমি ডিপ্রেস না, মা খুব ডিপ্রেসড. So it depends on the time. Demonetizationের পরে অনেকে বেশি ডিপ্রেসড হয়ে গেল, so that doesn't mean টাইমের মধ্যে জিজ্ঞেস করতে হবে. So now this I think is one of the largest study which I was part of to see prevalence of depression in type 2 diabetes. Here in Kolkata, we had about 1371 type 2 diabetes যারা এসছে আউটডোরে, তাদের কোনো ডায়াগনোসিস নেই ডিপ্রেশনে, কোনো অ্যান্টিডিপ্রেশন খায় না, এরা এসেছে, এদেরকে আমরা PHQ-9 কোয়েশ্চেনের দিয়ে দেখা যে কত পার্সেন্ট ডিপ্রেসড অ্যাকচুয়ালি আছে, ইজ দিস আ প্রবলেম অ্যাট অল? অ্যান্ড actually if you see 36% had minor depression and 4% had major depression and 14% had suicidal ideation. It is a serious issue. তো আমরা এটা দেখার চেষ্টা করলাম যে কার সাথে কোরিলেশন আছে, তাহলে ইয়াঙ্গার এজ, ফিমেলস, লোয়ার সোশিওইকোনমিক স্ট্যাটাস, যাদের হাইপোগ্লাইসেমিয়া হচ্ছে তাদের, BMI-এর সাথে নেই, তাহলে ওবিস পেশেন্ট একটু বেশি ডিপ্রেসড হলো না, আমি খুব খুশি হলাম তাতে যে ওবিস পেশেন্ট হতো আমিও ডিপ্রেসড হয়ে যেতাম, but there wasn't any relation. But what I'm trying to say, this is important, we miss it big time. কারণ কে করবে এখন PHQ-9 কোয়েশ্চেনের দেবে পেশেন্টদের, তো এই 36% যাদের রয়েছে তারা রয়েই গেল. So we have to think of which medications help it. The best data is with pioglitazone. So there are multiple trials done with pioglitazone, and in so many trials that there have been a meta-analysis which shows that pioglitazone really helps in depression. You can see it's about 32% reduction. And antidepressanted 2 থেকে 4 সপ্তাহ লাগে কাজ শুরু হতে, pioglitazoneের 8 weeks লাগে গ্লাইসেমিক কন্ট্রোল করতে, কিন্তু অ্যান্টিডিপ্রেসেন্ট এফেক্টটা খুব তাড়াতাড়ি চলে আসে. Now we are doing a consensus on depression, and I was given the task of collating the data of oral hypoglycemic agents and insulin on depression. So best evidence we have is pioglitazone. Metformin and DPP-4 possible. Insulin kono আর SGLT2 inconclusive. GLP-1 receptor agonist again possible. কিন্তু সবচেয়ে ভালো ডেটা কিন্তু pioglitazone. So repurpose করতে হলে, if somebody asks me, I'm not telling you to give pioglitazone to everybody with depression. কিন্তু এটা একটা repurpose যদি করতে হয়, pioglitazone should be there at the back of our head. Now, the NFLD and diabetes, it is important to note few things. অনেক terminology আছে. Histologic resolution of NASH with no worsening of liver fibrosis, improvement in liver fibrosis without worsening of NASH, very, very confusing. তো এটা মনে রাখতে হবে, একবার ফাইব্রোসিস সেট ইন করে গেলে আর ওটাকে ঠিক করা যায় না। আগে ইনফ্লামেশন বিট আসে, তারপরে ফাইব্রোসিস। ইনফ্লামেশন বিটটাকে কমানো যাচ্ছে, ফাইব্রোসিস হয়ে গেলে খুব মুশকিল। দ্যাট ইজ ওয়াই ইউ সি ডেটা উইথ GLP-1 receptor agonist. Best data with GLP-1 is with semaglutide, then followed by liraglutide. Best data. এখানে it is ওয়ানটাকে টাচ করে যাচ্ছে। সো ফাইব্রোসিস আর ঠিক করতে পারছে না। কিন্তু এইখানে এখানে, mind you, this is not the central line, 1 is here. So great improvement in resolution of NASH. So if you have to really give the GLP-1 receptor agonists to patients with NFLD, we have to give it early. The earlier you get, the better. Ekbar fibrosis hoye gele, then you will not have that much of an effect. Tirzepatide, you've got new data which suggests a resolution of the NASH. Retatrutide, triple agonist, you can see resolution of NFLD about more than 90%, and fat reduction of more than 70%, fat reduction more than 70-80% in upore. Great. We have to see whether it reduces the fibrosis. So we have to remember, type 2 diabetes, advanced fibrosis 6 to 20% already রয়েছে আমরা যে পেশেন্টগুলোকে দেখছি। Now this is the AASLD 2023 guideline. ওরা সাবমিট করেছে যে oral hypoglycemic agents, diabetes agents there, data on NFLD. Okay, I'll just finish in 2 minutes. Data on NFLD. So you will see here, vitamin E, এতে বলেছে no proven benefit on fibrosis. Without type 2 diabetes. Type 2 diabetes এ vitamin E এর কোনো রোল নেই as far as trials are concerned. Non-diabetic patientদের আছে। But if you look everywhere, liraglutide improves steatosis, no impact on fibrosis. Semaglutide improves steatosis, no benefit on fibrosis. Tirzepatide, এখনো fibrosis data এখনো আসেনি। SGLT2 inhibitor, reduction in steatosis by imaging, কারণ অতগুলো biopsy driven data নেই SGLT2 meaningful impact হওয়ার জন্য। But if you look at pioglitazone, এটি একমাত্র যেখানে লিখেছে fibrosis improvement question mark, মানে হতে পারে হয়তো, there was one trial which did show some improvement, আর কোনোটাতে fibrosis এখানে খালি একমাত্র pioglitazone লেখা আছে। So for me, I would say the best drug, if you ask me the best drug, I'll say pio plus SGLT2 plus GLP-1 triple. এটা দিয়ে ট্রায়াল করতে পারলে ব্রিলিয়েন্ট এফেক্ট হবে যে কতখানি ন্যাশ কমালাম আর কতখানি ফাইব্রোসিস কমালাম। So I think, Chairperson Sir, I'll have to end here. I had got other slides with HFpEF, but I will discontinue that. So it is last year, the metformin, ursodeoxycholic acid, which we write left, right and center, DPP-4 statin, they should not be used as a treatment for NASH as they do not offer any meaningful histological benefit. Fibrosis is নয়, NASH-ও কমায় না, steatosis, hepatitis-টাও কমায় না. So therefore there is no role for all of this in NFLD. So with that I end. Thank you very much.
Thank you, Dr. Gangopadhyay, and I think it was an excellent talk. What I would like to know is the patients you chose in the study, they were already on pioglitazone as part of their treatment, or they were put on pioglitazone?
Which patients?
The study that you did with patients on depression and diabetes?
No. They were not. They were just random patients you and me see.
Selection.
So when they came to us, we just did the depression score. We did not look at correlation of individual drugs,
Okay.
whether they were on. It's just a cross-sectional data of patients who just came to our clinic and not on antidepressants and no diagnosis of depression. We just gave the questionnaire and found.
So I think it would be interesting for the audience to know that you did the study with pioglitazone that showed improvement in depression, but what was the effect on the HFpEF of those patients?
Okay. So we don't have data on the HFpEF for those patients, but I feel that if at all, pioglitazone probably will have a beneficial effect on that. But if somebody is stamped with the diagnosis of heart failure, we are mandated not to give pioglitazone. So we cannot give. So then that excludes the use of pioglitazone. Pioglitazone had its baggage, macular edema, osteoporosis, and heart failure.
Sir, what's about saroglitazar in the context of
Yes,
fibrosis?
so it's an Indian drug, and it is cheap or cheaper than many drugs. But so far, it has not made its way to any of the guidelines yet, partly because we lack good quality, long-term, histological data to suggest. You will get SGPT, SGOT reduction with even DPP-4 inhibitors. Many drugs will reduce the SGOT, SGPT. You will get radiological evidence of reduction. But we need histological proof. That big volume for a long period of time is lacking with saroglitazole. So we don't have data.
Any question from the floor?
Yeah, Kalyan, nice talk as usual. The most important part I liked is you have taken a case-based kind of approach. I mean, a disease and you repurpose the anti-diabetic drug. The two issues that comes to my mind. One is CPAP. You have elaborated on that. We know that when we are putting a OSA patient on CPAP, you know, the latency of sleep, which we advocate to be 7 or 8 hours, improves, and all kinds of daytime somnolence goes away. And along with that, the sympathetic overdrive also go away. So that should have been reflected in cardiovascular outcome, which you said is not. That is something perplexing to me, number one. And second is, pioglitazone, how do you, I mean, kind of, what is the mechanistics maybe as far as OSA improvement is concerned?
No, pioglitazone, there's no role in OSA. Depression there is. So OSA, there's no role of pioglitazone. So, one minute, one question at a time. So, your first point is absolutely valid. If I am reducing the sleep, improving the sleep quality, I'm reducing the sympathetic overdrive, why should it not? I think the problem lies with the studies, because many of the times they have seen on average, when you prescribe CPAP to a patient, they are religiously taking the CPAP for only 4 hours. So you have to do a study and show that those who have religiously taken it for their entire duration of sleep, like we have treatment estimand sort of thing, those patients, whether they have reduction in their cardiovascular outcome. We've taken all the patients, but many don't use it for the full duration of their sleep. That is the problem. Yes, your question? No, don't know. We don't know. There is no clear mechanism. So if you read the literature, they will cite many things that in general, it corrects the inflammatory pathway, it improves the insulin sensitivity. You know, there is insulin nasal spray has been tried for various CNS disorders to overcome the insulin. Now here, they have said probably the insulin sensitizing effect plays a role, the inflammatory reduction plays a role all over the body, that includes the brain. But there is no clear mechanism. But what we are seeing is there is clear reduction in the depression. Now for SGLT2 as well, we didn't know why it reduces the CVOT when it first came. It was just done, a trial was done to show CV safety, not efficacy, but it showed. Now we are looking at why it is showing.
And the SGLT2 with OSD.
Sorry?
In SGLT2, role of SGLT2 in OSD. OSA. That is also shows that you have did not show any whether the patient's having on CPAP or not. For GLP-1, some patient on CPAP, some patient without CPAP. For SGLT2,
No,
the
we don't
data
have
was
any
not
data.
there.
We don't have any data for patients with CPAP, without CPAP. So this is, we have either prevention of new diagnosis of OSA, that data we have 52% reduction, and patients who are already on CPAP we have. But the tirzepatide trial, that's why I was emphasizing, it's a very good trial because it was divided clearly into two groups, CPAP, no CPAP, same reduction in the AHI score. That sort of trial is not there with the SGLT2 inhibitors.
Okay, thank you.
Hello. What role of sir?
Yes, so I think for the SGLT2, it seems it is independent of the weight reduction. For the GLP-1, probably more you lose weight, the better it is for the OSA. But if you combine both, I think it will get great benefit.
Sir, another
Yes.
question.
What is the role of seroglitazar in case of decreasing fibrosis in liver? Seroglitazar.
Sorry, I think he asked the question, I just answered it. We don't have enough data for histological data yet. All we have data is
good.
mainly liver enzymes and radiological data. Long-term, good quality histological data is lacking for saroglitazar at this point of time.
Thank you very much. Now let us close the session. It's too much. Okay, thank you.
Thank you, Speaker, sir. Thank you, chairpersons.